Good morning, and thank you very much for the opportunity to speak here today. And today I'll discuss the results of our selective program of lung volume reduction surgery for upper lobe predominant emphysema instituted at the Cleveland Clinic since the publication of the National Emphysema Treatment Trial, and I have no disclosures. To review, the NETT was a randomized trial published in May of 2003 that compared lung volume reduction surgery to best medical therapy for palliation of patients with severe emphysema. This slide shows the study design. 1,218 patients satisfied inclusion criteria, from which 140 were excluded due to prohibitive surgical risks due to homogeneous emphysema or an FEV1 or DLCO that was less than 20% of predicted. This left 4 groups for which to compare LVRS and medical therapy: upper lobe predominant disease in low exercise capacity, upper lobe predominant disease in high exercise capacity, non-upper lobe predominant disease in low exercise capacity, and non-upper lobe disease in high exercise capacity. In this slide shows the only group of patients in which lung volume reduction surgery demonstrated a survival advantage. Surgical patients, shown in orange, with upper lobe predominant disease and low exercise capacity had a significant survival advantage over medically treated patients, shown in white. And the NETT paper concludes that LVRS does yield a survival advantage for patients with both predominantly upper lobe emphysema and low baseline exercise capacity. And based on these findings, we established a multidisciplinary lung volume reduction program at the Cleveland Clinic in 2004 that offered surgery only to patients fulfilling the criteria of upper lobe predominant disease with clinically low exercise capacity. And the objective of the study was to evaluate the outcomes of a LVRS program focused exclusively on patients with upper lobe predominant emphysema with attention to baseline exercise capacity, and to describe our screening and multidisciplinary follow-up. Endpoints for our study included survival, change in FEV1 %, exercise capacity, and health-related quality of life. To be considered an LVRS candidate, patients must first fulfill the rigorous NETT inclusion criteria. In addition, patients are required to have clinical low exercise capacity, upper lobe disease, FEV1 and DLCO greater than 20% are predicted. Additionally, they're required to have 6 months of smoking cessation and to undergo at least 10 weeks of pulmonary rehabilitation. Screening tests include chest CT with 0 to 4 radiologic emphysema scoring, pulmonary function tests, ventilation perfusion scanning, 6-minute walk test, dobutamine echocardiogram, cardiopulmonary exercise testing, quality of life assessment with the St. George Respiratory Questionnaire, as well as a thoracic surgery and pulmonary medicine evaluation. Postoperative follow-up includes chest radiographs, pulmonary function tests, cardiopulmonary exercise testing, and quality of life scoring, all performed at 6 months, 1, 2, 3, 4, and 5 years after surgery. This is a typical preoperative chest radiograph of a patient undergoing LVRS, showing a large AP diameter in bilateral flattened hemidiaphragms. This is a typical chest CT, demonstrating severe emphysema in the upper lung zones with relative preservation of the lower basilar lung zones. This slide shows the demographics, complications, length of stay, and follow-up of the 27 patients undergoing LVRS from April 2004 to January 2012. Median age was 64 with a range from 40 to 78. 44% of the patients were male. Median FEV1 was 26% of predicted. Postoperative complications included prolonged air leak in 56%, atrial fibrillation in 15%, and pneumonia in 7%. Median hospital stay was 8.5 days, and follow-up was 3.9 years median. Moving to our results, starting with survival, we had no operative deaths, 1 3 and 5 year survival was 96, 96, and 75% respectively at the median follow-up of 3.9 years. We next looked at the percent improvement of FEV1 over baseline. At 6 months, 1 year, and 2 years after surgery, FEV1 improved by 56, 28, and 30% respectively. We next looked at the percent improvement of work capacity over baseline compared after cardiopulmonary exercise testing. At 6 months, 1 year, and 2 years after surgery, FEV1 improved by 48, 33, and 45% respectively. Finally, we looked at the percent improvement of quality of life over baseline measured by the St. George Respiratory Questionnaire. At 6 months, 1 year, 2 years after surgery, the St. George Respiratory Questionnaire score improved by 48, 42, and 22% respectively. So in conclusion, rigorous application of the NETT findings in a multidisciplinary setting continues to result in excellent outcomes. Objective and subjective improvement in pulmonary function persists in LVRS patients at median follow-up. LVRS should remain an important therapeutic option for selected patients with advanced emphysema. Thank you.